Hi, this is Nancy Hiltz. I'm the orthopedic clinical specialist at the Kaplan Joint Center. And today I'm going to, with my colleague Dina Murad, one of our senior physical therapists, we're going to give you an overview of the process of total knee replacement surgery. Things are a little different now. Where usually do these classes live, so we just wanted to provide that same information. Your healthcare team, Dean, is going to show you the masks that are going to be being worn during your hospital stay. You'll have a mask. Your healthcare team will have some kind of mask. It might look a little bit different. They may also have goggles. The hospital has done a really great job in preparing the surgical floor for patients coming back in so that it's very, very safe. But we want you to feel free to ask any member of the healthcare team, if you have your physician's office as well, if you have any specific concerns regarding that. So without further ado, we'll talk about knee surgery. So what usually brings someone in to see the orthopedic surgeon is when the pain has increased or the mobility has decreased and is interfering with your activities of daily living. In the old days, people were told to wait until they couldn't walk, but that really has changed because the prosthetics that we have available have longevity that they didn't have, and people want to stay more active. So what really is the trigger is when those limitations are interfering with what you need and want to do. And it'll be a little different for everyone. So if we took a look at a model of a knee, minus all the soft tissue, your knee is a hinge joint. It bends and straightens, bends and straightens. It's made up of your thigh bone, your femur, and the large bone in your calf, your tibia. There's also a kneecap, your patella. My model doesn't have one, but I will show you what we do with that in some of the other models. So when this joint is healthy, these bony surfaces that glide over one another have a protective covering called articular cartilage. When it's healthy, it's great because it allows pain-free, friction-free motion. But that type of cartilage has no blood supply and no ability to repair itself. So we put wear and tear on the joint, that cartilage will start to crack and fray and wear out, and you get areas where you're bone on bone. On your tibia, the articular cartilage covers it. On top of that sits your meniscus. Your meniscus is a different type of cartilage. By the time you're a candidate for a knee replacement, that meniscus is pretty much churned up, and that will be removed as part of the surgery itself. So there's also a capsule. It's a fibrous ligamentous capsule that surrounds the joint. It has a special lining called synovial tissue, and that secretes fluid within the joint. When you're having surgery, that capsule has to be open to gain access to the bone, but it's surgically repaired at the end of surgery. So I just want to show you in this picture here, you can see the kneecap. The kneecap sits in the groove at the end of the femur. It's the undersurface of your kneecap that rides up against the femur here. So in this picture, the white indicates all the healthy cartilage. So after surgery, your kneecap will feel the same, but it's the undersurface that they're going to have worked on. So if we look at x-rays of a healthy knee and a not so healthy knee, this would be our healthy knee here. You can see there's space between the femur and the tibia. Cartilage doesn't show up on x-ray, so when we have that space, that tells us that there's good cartilage there. And again, you can see the little kneecap sitting there. This is what an arthritic knee looks like. The bone is sitting on top of the bone because we've worn out all of that articular cartilage. And now the bone is scraping on bone, which causes the pain, and it also causes inflammation within that joint capsule. So it's stiff, achy, tight, swollen, none of it's good. But the good thing is there's a lot we can do to make it better. So your surgeon is going to use your preoperative x-rays to template which prosthetic is best suited for you. Okay, so on this model, the loose site is all your bone. They've made it clear so I can show you how the prosthetics are going to fit into it. So here's our femur, and here's our tibia. So what the doctor's going to do when they do the surgery is the incision goes right over the front of the knee, and they're going to open up that capsule. You'll be in your happy place when this is going on with no recollection. And so what they're going to do is they resurface the joints. Sometimes people think that they're taking out all of this bone and putting in a whole new joint. But what they're doing is they're cleaning up the arthritic ends of the bone. So on the femur side, they're going to take off all that articular cartilage that's damaged, and they're going to angle the bone so that it accommodates the undersurface of the prosthetic that looks like this. And that's going to fit right over. So now we have a smooth surface once again. And these prosthetics get cemented to the bone. On the tibia side, they're going to take off all the damaged cartilage. If you've worn really unevenly, if you're very bow-legged or knock-kneed, they can, with the way that they make the cuts in the bone, bring you to a more neutral position. And then the prosthetic that goes in the tibia is a metal tray, and then on top of it sits a plastic tray. And that plastic tray has little concave surfaces. So now you're smooth on smooth once again. So they use trial components, and I make it sound like they go in and go swoop, swoop, swoop. But every cut they make in the bone is guided by their equipment, because they are keeping all the same tension on the soft tissues that cross the joint. Now, this model also does not have a kneecap, but what they use is, it's called a patella button, and it's a little plastic, it looks like a little plastic flying saucer. And so that gets inserted on the undersurface of your kneecap, and your kneecap is sitting right here. So the plastic will ride up against the metal. So now all of the surfaces that move over one another are metal and plastic, so that that arthritic surface has been replaced, so that that arthritic pain is gone. Now, we substitute some postoperative discomfort, and we're going to talk about that in a minute. But the good thing about the postoperative pain is it will get better. You know, we've fixed the problem, and a lot of the postoperative discomfort is really the soft tissues and the swelling. And if we were really kind and let you put it on a big bed pillow and just rest there, you'd think it was easy peasy. But the physical therapist is going to get that moving again, because that's how you're going to get your best results. So that's the surgery part. Now, as you get ready for surgery, we're going to ask you to have a pre-op visit. Sometimes the doctor's office has you go to your primary care. Some offices have you come into their office, and they'll just do a history and physical about the knee joint, but also any other comorbid conditions that you have. So we want to know about all of you. They'll look at the medications you're on as well. You'll have a pre-test telephone call from a nurse in our pre-test unit that will go over some things. You'll also get a telephone call or visit, depending on where we're at with face-to-face, from Dina, who's our pre-op coordinator. And she's going to talk more about what goes on in that visit when I finish my piece of this. So what's going to happen is we want to make sure that you're healthy, ready for surgery. They'll give you directions. We do ask you to shower with a special soap a few days before surgery, and that just leaves a little antibacterial film, and that helps as infection prevention. We also test everyone now for the COVID virus, and that will be explained during your telephone call with your pre-test nurse. The other things that we do for infection prevention is during surgery, you'll get a dose of antibiotic before surgery and 2 doses after surgery, and that's just a standard protocol. So by layering these preventative measures, we're really able to minimize the risk of infection after surgery. And our infection rate for the past 9 or 10 years has actually been less than 1%, which is less than the national average. We always aim for 0, but that's a good statistic that we're very proud of. So at the end of your pre-op visits, you're going to have an understanding of when you come to the hospital. And we usually ask you to be here an hour to 2 hours before surgery. Your doctor's office will confirm that time. Now, with the COVID virus, we are no longer able to have family members in with you. One of the things that I suggest is you can keep your phone with you in the pre-op area the day of surgery, and they can just put it with your belongings when you go over to the OR. So if you want to be able to speak with your family or maybe have them on speaker when the doctor's in, you certainly are able to do that. So day of surgery, you're going to come in, they're going to bring you to our pre-op area, they'll change you into our hospital attire. Your surgeon is going to be over to see you. He's going to ask what knee is being done that day. Now, he knows the answer to that question, but that's called site verification. And he will initial the knee that's going to be done. When you go into the OR, you'll be sedated, but before surgery begins, your surgeon also pulls the entire OR team, and everyone has to say what side and what procedure is being done. I remind people that your surgeon is your captive audience then, so if you have any last minute questions, it's a good time to pose them. And then your anesthesia team will come over. So it'll be your anesthesiologist and nurse anesthetist that will be in the room with you. And they're going to start your intravenous catheter. We give you fluids, some of your medications through that. They're also going to start your pain management. So the way we manage your pain after surgery is called multimodal. And that's just a fancy term. It just means we use a bunch of modalities at different times and they work synergistically together. So pre-op, they're going to give you a Tylenol, Lyrica, and Celebrex. All three of those medications block pain in a different way. So having them in your bloodstream before we begin surgery prevents the pain from rising as high. If there were any of those medications you couldn't take because of an allergy or sensitivity, they just eliminate that one. They're also going to offer you a nerve block. A nerve block is when they inject Novocaine into the nerve that brings the pain impulses to the top and sides of your knee. So it's an additive way that we can manage pain. And they can answer any questions about the pros and cons about that. We have found as we look at our patients post-operatively, those that get the nerve block seem to use less narcotic, require less narcotic after surgery. So when it's time to go to surgery, it'll be that anesthesia group that takes you on the stretcher bed into the OR through the double doors. And on the ride down, they give you a little sedative medication that we call the happy juice. And for most people, they have no recollection of what's going to go on once they get what has gone on in the OR itself. One of the additional things that they can do for pain management is at the end of surgery, when your surgeon is closing all the soft tissue, the capsule, the muscles, the incision, they will inject a little anti-inflammatory Novocaine cocktail into all the soft tissues. And what we find is that people wake up, and the majority of people have very little pain while that Novocaine is in. And then that anti-inflammatory medicine really helps cool down the inflammation. So it's another way that we're able to manage your pain. So when you go into the OR, you move from the stretcher bed to the operating room table. A sterile scrub is done of that whole leg. Anesthesia is administered, surgery is performed. And then at the end of surgery, you're moved right from the operating room table into your hospital bed. And the whole hospital bed goes out into the PACU. And the PACU is the recovery room. It's called the post-anesthesia care unit. So when you awaken in the PACU, you're going to be in bed, on your back. You will have oxygen. Most often it's those little nasal cannulas with a little clip on your finger that tells us how much oxygen is getting to your blood. You'll have your intravenous fluids running. You'll have a dressing on your leg. The dressing that we use is called Aquacel. So it stays on for 7 days after surgery. You may have elastic hose over that. You may have an ACE wrap over that. And then you'll have little inflatable cuffs on your calves that pump air every minute, and that helps with the circulation. Dr. Badair uses a wound drain so that Dr. Badair's patients would have a very small tube coming out from under the dressing. That next morning they pull the drain. It's not sutured in, it's just placed, so it does slide right out. So those are all the things that you can expect in the recovery room. You know, some people sleep a lot, some people are wakeful, but the nurses will make sure that you're comfortable, your blood pressure's good, heart rate's good, that you're feeling well, and that's when you'll be moved up to the nursing unit. So post-op, when you arrive to the nursing unit, your nurse is going to have gotten report from the PACU nurse, so she'll know how things have gone. Our goals for you the day of surgery is your comfort, progress your diet, and get you up for a stroll. So you'll get back your vital signs, blood pressure, pulse, temperature get taken very frequently, especially that first 24 hours. So they'll give you something light. If that sits well in your stomach, then your diet is going to be progressed. And the way that they do diet, the dietary department is a room service menu. So you call down half hour, 45 minutes before you want your breakfast, lunch, dinner, and it magically appears. And they can accommodate any diet. The way we manage your comfort after surgery is you will have an ice wrap that circles that leg. That's part of your post-operative dressing, and we actually will send you home with that. While you're here with us, we ice pretty much round the clock. Ice helps with the swelling. If you can limit the swelling, it helps with the comfort as well as the motion. And it also numbs things up. You'll receive extra strength Tylenol every 8 hours. You'll receive a medication called Toradol through your intravenous, which is an anti-inflammatory medication, every 6 hours for the first 24 to 48 hours. And then there'll be a pain pill. And most often it's an opioid oxycodone or Dilaudid that's available for you, and your nursing staff, your therapy staff, everyone is going to be asking you to rate your pain so that we can figure out what's going to work best for you. Whatever medication that you're on here is the medication that the prescription will be given to you when you're discharged home. So when you leave us, you'll get a paper prescription that you fill at your local pharmacy. If you were to need a renewal on that, you just call the doctor's office and they're able now to electronically send that to your pharmacy so that no one would have to come back into the office. The most important thing with pain management is that you communicate with us. If what we're giving you isn't working, we want to be able to make some adjustments so that we know you're going to be in a good spot when you go home. So it's one time that we really encourage you to complain right away if it's not working. And as I said, you'll get tired of the nurses and therapists asking you, how's your pain? On a scale of 1 to 10, how's your pain? How is it after your medicine? So if your surgery is in the morning and you're feeling well, you may see your physical therapist in the afternoon. If your surgery is later in the day, or maybe I got up and I was a little lightheaded, so I needed more anesthesia out, more fluids in, it may be the nursing staff that gets you up for the first time. But our goal is to get everyone up. You can put as much weight on that leg as you're comfortable with. We start everyone with a walker for support, and then your therapist will progress you to crutches if that's appropriate. And Dina will talk a little bit more about that. The first night is not a restful one. They're in at you quite a bit, taking your vital signs, checking if you need pain medicine, hanging your antibiotics, hanging your Toradol. So I frequently get that in the morning, people will tell me they were in here every time I turned around. And I say, is that a bad thing or is that a good thing? They were checking on you, but it's just something that needs to be done. The other member of the healthcare team that you will meet is your case manager. So the case manager's role is to assist with discharge planning. The majority of our patients are able to transition directly home, most often just with a one-night stay, sometimes two. For us, it's all about achieving safety and independence. We need you to be comfortable on your medications. We need you to be able to get in and out of bed, on and off a chair, manage in the bathroom. We need you to be able to walk 150 feet and do stairs if that's appropriate. So those are the things that we want you to accomplish before you go home. And then we will send a home care agency in, usually for the first 2.5 weeks. So usually a nurse will come in once or twice, and she'll make sure you understand your medications, if there's any wound care issues. The dressing that we put on after surgery stays on for 7 days. Sutures and staples stay in for 12 to 14, and they would get removed in your home by the home care folks. They get the same orders that we send you home with, so everyone is on the same page. If someone really is very deconditioned and is struggling with those goals of safety, then the recommendation would be for an extended care facility, and the case manager can help with that as well. So they make all those arrangements. They let you know who the home care agency is going to be. We do ask our home care partners to be in to see you the day after surgery. So all of that is taken care of. So post-op day 1, your intravenous is discontinued. You're going to work with physical therapy. You may see occupational therapy, and Dean is going to speak to those. The case manager will confirm the discharge plan. She'll confirm who the home care agency is. And when you're ready, once you hit all those goals and you're ready to go home, you'll get a full set of instructions. It'll have all your medications. It'll have your wound care. You are able to shower, and that Aquacel dressing is waterproof. When that Aquacel comes off, I usually tell people to wrap plastic around it until the staples or sutures are removed, which is another week. And the home care folks will give you that guidance as well. Your follow-up appointment, signs and symptoms to report to the physician. The other medication that everyone will be on after surgery is a blood thinner to prevent blood clots. So if your only risk of forming a blood clot is your knee surgery, you would be on a baby aspirin twice a day for 6 weeks. If you had other health issues that increased your risk, you may be on Eliquis, Xarelto, but your surgeon will make that determination before surgery, and that medication will be reviewed with you prior to going home. When it's time to go home, your family will be called, because as I said, right now there's no visitors there, but family can feel free to call. You can keep your cell phone with you. They can, check in with your nurses at any time, but they would be called when it was time for you to be discharged, and one of the staff brings you down and gets you in the car in our little pickup area. When you get home, especially that first night, crash. It's a lot of activity within a very short period of time. And I think people kind of are running on adrenaline. You're so happy surgery's over, and look, I can do this. I did the stairs, it's okay. And then you get home and it's like, oh. So get home, put the ice on, and get it elevated. Dean is going to go over the exercises that you do while you're here at the hospital. We focus a lot on the bending and the extending. But when you get home 3 to 4 times a day, my mantra is, I want your toes higher than your nose, because that's really going to help control swelling. And if you can control swelling, it makes the motion easier, and it also enhances your comfort. The last thing that I just like to mention to people is all of the doctor's offices want you to call with any questions. So if you're not sure about something, you're wondering, is this normal? Just call. The home care agency is really good about calling when they're in too, if they're concerned about is swelling or anything going on. So someone is always there to address those concerns. So we want to make sure that you know that we'd rather hear from you than have you worrying about something. So that's kind of the medical nursing picture. So I'm going to turn it over now to Dina, and she's going to review all the fun you're going to have with therapy.
Hi, so I'm Dina. I'm one of the physical therapists at Newton-Wellesley Hospital, but I also work as the pre-test preoperative coordinator. So what does that really mean? I'll likely, given this time of COVID, that I'll probably be giving you a phone call just to ask you about your current mobility status and your home setup. And this can help us best serve you during your admission at Newton-Wellesley. We love to be prepared. We love to hear about complex social situations set up so that we can try to problem solve some of that stuff prior to you coming in. So that's what I will be, expecting, you to hear from me preoperatively. But really the first time you see your physical therapist after surgery, as Nancy mentioned, maybe as early as that same evening after surgery. And really, what sort of determines whether we'll see the patient or defer until the morning is partly sometimes what time you come up from the operating room, how you're feeling, are you dizzy, lightheaded, how's your pain level? So we'll be assessing all of those things with your nursing staff to make sure it's appropriate for us to visit you that first evening. And regardless of when we see you, you will get up that first night of surgery, whether it's with PT or nursing. I always sort of say the goal of the first night is pretty much to pee. So that might be standing at the bedside using a urinal or a commode. it may be walking into the bathroom, or you may be doing some laps in the hallways. If you're not the person doing the laps in the hallways, please do not be disheartened. It has zero indication about how the rest of your admission is going to go. But really the goal of that first PT session is what we call our evaluation. We're going to be evaluating your whole body. So we're going to start by confirming your social situation, again, your home setup, and then we're going to assess your whole body, such as your arms, making sure that if you have any arthritis in your shoulders or prior injuries that we should be aware of, that might be useful information for us in determining what's the most beneficial assistive device for you to be using post-surgery. We'll assess your non-operated leg and then your operated leg. Chances are you'll be in bed the first time we see you, so we will start to introduce you to your home exercise program. They are very basic in the beginning. Some exercises you'll be able to do till the cows come home, and some exercises are a little bit tougher, and we're going to sort of restrict the number of repetitions that you're going to do, because it is a fine balance of doing activity but not doing too much that we may over irritate a freshly operated joint. So we'll teach you those exercises. Some are, as I said, going to be a little bit more challenging, so there are some tricks to getting those done. And it's really starting to work on getting that knee bending and straightening. What you'll find when you probably wake up from the operating room, that not only do you have those cuffs around your legs, you might find a rolled up towel underneath your ankle. The reason that is done is because we want to, when you're resting, keep that leg positioned in a nice straight position, the knee especially, because we're very concerned about making sure we get that range of motion back as early as we humanly can. So whenever you're not doing your exercises, we want you resting in that position. I know Nancy also mentioned about getting your leg up and elevated, which is really important in managing your swelling. I'm going to share my screen so you can sort of see a picture of what I'm talking about. So bear with me. Ta-da! So in this picture, you can see how they have staggered the pillows. So that way they're, one, elevating the leg, but two, elevating it in a manner that the knee remains straight. We don't want you resting in a bent position because we don't want your knee to scar down in that position. Sometimes an additional towel roll underneath the ankle can help with getting that leg straighter. So that's sort of an example. So if you're at home now, start preparing your pillows. Make sure you've got enough of them. So I'm going to just go back to my regular screen. So that's a way that we want you positioning your leg to help with that swelling control. Swelling it occurs as part of surgery. It's sort of the evil, as I say. I mean, but it's the evil, but it's the things that bring the good nutrients to stimulate the healing process of that knee. But it obviously can help, it can restrict your range of motion. It can make your muscles feel a little weaker than they would do normally. And that's all normal. That operated leg is going to feel a lot tougher to move than it did prior to surgery. The muscles are going to feel weaker. And that's again why the exercises are introduced early on, to start to remind those muscles what they're there to do. So we'll teach you that program. So once you've gone through that exercise program, and you're still laying in bed, we're going to check your blood pressure, your heart rate. Lots of blood pressure checks the first time we start to get you up and moving. It is the sure way that we can know how your body is responding to everything after surgery. So we're going to check it in bed. If it looks good, we're going to proceed to sitting you up to the edge of the bed. Some patients are able to get themselves up to the edge of the bed without much difficulty. Some patients require some assistance, whether it's guiding the operated leg or some assistance for their upper body as well. Once you're sitting at the edge of the bed, we're going to ask you about your head. We're going to be asking, are you dizzy? Are you lightheaded? And you're going to be like, why doesn't she care about my knee? So we want to make sure that your head and is feeling the way it should be after surgery. So we'll sit you up at the edge of the bed. We'll recheck your blood pressure. It is not unusual the first time you go to get up that you might feel dizzy, lightheaded, or nauseous. And that can be a result of the blood pressure just fluctuating a little bit. Your body's gone through a lot through surgery. Sometimes it just takes a meal and some extra fluids for your body to sort of be like, okay, I'm good, before we can proceed to mobilizing. So if your blood pressure is stable or if it goes up, we're going to progress into a standing position. If it drops or if you're feeling dizzy or lightheaded, we may lay you back down and decide to try it again a little bit later to just give your body some more time to recover after surgery. So the first time we go to get a patient up, as Nancy mentioned, we start everyone using a walker. It's just the sturdiest of all the devices. We do anticipate you are going to be allowed to put weight through your operated leg without any restriction. So we'll teach you the safe hand placements and how to stand up. Once you're in standing, again, we're going to ask you how your head is feeling. If you're dizzy, lightheaded, if you're feeling good, we're going to take some steps. Again, how far we go that first time you're up walking is dependent on how you're feeling. As I mentioned, some patients are walking into a bathroom, some patients are doing laps in the hallways. We're going to pace your activity based on your tolerance, okay? And I just stress again, please don't be disheartened if you don't progress so much that first time you work with us. Again, we will tailor your sessions based on how you're doing, okay? Our subsequent PT visits will include the re-educating you on the exercise program, but also starting to transition you maybe from a walker to crutches if we feel that that's a safe plan. And it's really starting to work towards those goals for home. So as Nancy mentioned, before we let you go home, we want to make sure that you're independent with getting yourself in and out of the bed, that you're able to get up from a seated position into a stand from a variety of different surfaces using your crutches or a walker. So I say we want to make sure you can get up from a chair, toilet, your bed. We want you walking at least 150 feet. Most of our patients are probably walking double, if not triple that distance by the time they're ready to leave us. Again, using your walker or your crutches. And then if you have stairs that you need to tackle at home, we're going to make sure that you can do them. And so we're going to ask you questions like, do you have a railing? What side's the railing on? If there's no railing, or if there's steep stairs, we're going to make sure that you can tackle what you need to be able to do to get home and manage safely. Okay. So that's really it from a PT session, other than we usually always end our sessions with changing out your ice packs to make sure you've got nice, fresh, cold ice packs. Cannot stress enough the importance of icing in general, but especially after your PT session, because that's when we've done a lot of work. That's when you're going to have irritated the freshly operated knee. We want to manage that inflammation and swelling post PT. So get that ice pack on, get your leg up and elevated, and get it chilled. And really, we tend to say ice pretty consistently over the first 72 hours post-surgery. And after that 72 hours, ice, especially after PT sessions or a longer walk. But love ice as it's a non-medication form of one, pain management, and two, swelling control. So, you know, be conscientious that you bring your skin up to normal room temperature at least once an hour, just to minimize the risk of frostbite. But really, as you know, as you can tolerate, continue to ice that knee. Okay. You'll also see the occupational therapy staff while you're here in the hospital. The occupational therapy team work on the tasks of daily living. So tasks such as bathing, dressing, getting in and out of whatever shower setup you have at home, taking care of your personal hygiene, those sorts of tasks. So they are going to make sure that you can do those things before you go home. They have some equipment that can make your life easier. With a knee replacement, you really have no range of motion restriction other than obviously your pain. But also, you know, you have to potentially be aware of any other limitations. So I'm going to show you a couple of pieces of equipment. So I think probably the toughest thing that patients have a tough time is bending over to get a sock onto their foot, because bending that knee enough to get a sock on can be a challenge. So I'm going to share my screen again, and I'm going to show you a cool little item. So that's, I'll show you that in a minute. So this is called a sock aid. So it's sort of a hard semicircular, a semi-cylinder device that essentially you put your sock over the cylinder and you drop it down to the floor, you stick your foot into it and you slide it on, and it gets your sock on your foot. So really a neat item. God love Amazon. They usually tend to be the most reasonable, but a lot of medical equipment stores may sell this as well. The other things that you might find being beneficial, most people can stand up and take a shower, again, without much difficulty. But sometimes if you have, for example, a tub shower where you have to step into the shower to bathe yourself, having a seat in there can make it easier, because it can allow you to sort of sit down and then swing your legs over. I know this is placed in a shower, but it usually fits snugly into your bathtub as well. And you can, and the OT team will physically show you how to use this. This is similar to the one we use in the hospital. So I'm just going to leave the name up so that way you guys can have a look at it and maybe jot it down if you wish to purchase one. Sometimes I say you can pick up some of the stuff at a local senior center, although again, right now, given the current COVID situation, most people, most senior centers might not be open or maybe allowing the sharing of some of this equipment. So unfortunately, insurances don't tend to cover it. By far, Amazon has been the cheapest that I have found this equipment, and it gets delivered to your house. So certainly something to consider purchasing preoperatively if you feel like that might be beneficial for you. So I'm going to stop sharing the screen. So as Nancy mentioned, once you've met the PT and occupational therapy goals for going home, and you've medically cleared to go home, that's when you'll transition home. The case management team will set up a nurse and a PT to come to the house. The PT is usually coming into your house twice a week. They are continuing your exercise program at home, working on regaining that range of motion in the knee, but also starting to transition you off the crutches or the walker down to one crutch or a cane to eventually nothing at all. It is very much guided by your stability and your pain for when those transitions can occur. Once we, generally we say the home PT is great for 2.5 weeks. Then we want you into an outpatient world for physical therapy. It is a good idea preoperatively to decide where it is you wish to go for your outpatient PT. Once you know where you would like to go, give your surgeon's office a call. They can provide you with a prescription, or they can fax a prescription directly to the clinic you wish to go to. And then I recommend pre-booking those appointments, as I said, to start about 2.5 weeks from the time of your surgery. I say you want to book appointments twice a week, and I would say book a month's worth of visits. Again, given the current COVID situation, you may find that your outpatient physical therapy may be partly in person and partly part of a telehealth virtual visit. So, but your primary physical therapist will determine what is the most appropriate care for you. And it'll probably be very much based on how your range of motion is coming along and your level of need for guidance through that exercise program. So that's really it. How long people are in outpatient PT, it's very much determined upon how quickly your range of motion returns and your strength and what your long-term goals are in regards to your activity. So that's really it from a PT and an occupational therapy perspective. I'm going to hand it back over to Nancy and she'll finish everything up.
Thanks, Dina. So that's kind of the overview, and we are available for any additional questions. If you go on the Kaplan Joint Center website, there's an area where you normally would sign up for an education class, and my contact information is there, my email and my phone number, and I can certainly put you in touch with Dina if there are physical therapy specific questions. So we thank you for taking the time to watch this and hope that you found it helpful.